And take it away.
All right. Well, good afternoon, everyone. Great to have you all here. Happy end of December. So we're going to be talking about what pain in the neck, a guide to pediatric head and neck infections. And I think some of them are similar, as we'll see, to the adult world, and there are some differences that I'll be trying to highlight. So what I'm going to do today is I'll be presenting the differential diagnosis by location for common head and neck infections in peds. I'll be discussing clinical manifestations, the pathophys, complications, and then some management considerations to keep in mind. And I'm going to really try to highlight pearls and pitfalls to keep in mind, again, when assessing pediatric patients. So just starting off, let's start with painful red eye. So we'll be discussing orbital and periorbital infections. So, and this will be a case-by-case or a case-based discussion. So our first case is a 12-year-old with sinusitis and coming in with left-sided headache and left eye pain, and was found to have a left periorbital redness and swelling. So on imaging, we have a couple of representative MR images from their exam, and we can see that there's diffuse inflammation of the sinuses, so pansinusitis, as was discussed here and here. As we know, so orbital infections can spread from the adjacent paranasal sinuses, as we see in this case. And then we see inflammation in the periorbital soft tissues, as well as within the intraorbital soft tissues with this marked enhancement intraorbitally in the retrobulbar space. And that helps explain the proptosis that we're seeing on the imaging. Also important to note, just in terms of the symptomatology the patient may have, as denoted by the arrow, there is some inflammation and enhancement of the rectus muscles laterally and then superiorly, so secondary to myositis in this patient. Additional imaging from the same exam shows some complications to be aware of and to keep in mind. So if left untreated, these are some of the things that we can end up seeing in these patients. So foremost, we see superior ophthalmic vein thrombosis. So it's we don't see the typical enhancement we would expect. There's a void. And then we're also seeing intracranial spread of infection as well. So as denoted by the arrows, there is a frontal epidural empyema formation. We see peripheral enhancement around that, as well as internal restricted diffusion. So helping confirm that that's pus. Other things to look for that we're not seeing in this case are evidence of parenchymal abscess or cerebritis. But again, other things we want to keep in mind when we're assessing these patients. So this is a companion case of an 8-year-old who has known relapsed leukemia, and is presenting with neutropenic fevers and new left eye swelling. On the CT imaging at screen left, we can see that they've had it looks like some endoscopic sinus surgery. There's some missing bone structures there, but we notably can see some asymmetric attenuation within the left retroantral fat. So an important thing to look for in any immunocompromised patient, whenever you have views of that part of the face, always try to look and see if there's any asymmetric attenuation. So asymmetric attenuation, again, in that left retroantral fat in the pterygopalatine fossa. When we look at the MRI, we're seeing enhancement in those locations as well. We also see enhancement in the premaxillary soft tissues here, as well as in the left periorbital soft tissues. Another thing, so all concerning for infection and inflammation. Another thing that we're not necessarily seeing in this case, but it's important to look for as well on the post-contrast imaging, is any evidence of necrotic soft tissue, meaning non-enhancing paranasal sinus, sinonasal cavity soft tissues. So all these findings are classic for invasive fungal sinusitis. This patient had already, like I'd mentioned initially, they had an endoscopic sinus surgery to look for evidence of invasive fungal previously for this presentation. So this is an evidence of osseous erosion here, but this is the post-surgical change. But certainly on bone windows, trying to scrutinize the bone, looking for osseous erosion is another important thing to look for when you're worried about invasive fungal in patients like this. So ultimately, this patient was taken for extensive debridement. Ultimately, what the surgeons are trying to do is they're trying to debride the soft tissue until the histopath only demonstrates normal tissue. And sometimes, like I had mentioned, that non-enhancing soft tissue we can see in the sinonasal soft tissues. If you see non-enhancing tissue suggestive of necrotic tissue, that can be a good idea of kind of a rough measure of where your surgical margins are going to be preoperatively anyway. Biopsy for this patient was positive for rhizopus, and they went on to be treated with broad spectrum antifungals. And ultimately, this patient did well. They went home and is doing well now. So it's important. It's another point to keep in mind that while there is high mortality associated with this disease and this disease process, if you have early recognition and early aggressive treatment, there can be good outcomes, but there is high mortality that you want to keep in mind. So be diligent in assessing these patients. So our next patient is a 9-year-old who presented in the setting of trauma. So they had orbital injury after a dog bite. The CT imaging from their initial presentation shows a comminuted fracture at the right frontal sinus, superior orbital wall. And then we can see all this inflammation, injury in the soft tissues, some air, with not only in the periorbital soft tissues, but also within the extraconal space medially. And some of this was certainly related to a superimposed infection that was going on. The patient was treated with IV antibiotics, though, and did well. They were sent home, transitioned to oral antibiotics, and again, had improved symptoms. However, they did represent several months later with new symptoms. So they have sinusitis, but then also this new inflammation involving their right periorbital right periorbital soft tissues, which is what they saw on physical exam. And then on our imaging, we're seeing extension of that inflammation infection into the medial extraconal space of the right orbit. If we attention the area where we had seen the fracture previously, now there's this new discrete defect in that location. So a persistent fracture defect there. We can also tell that the bone doesn't look exactly normal in that location. It's a little mottled in appearance. And then notably, another reason for this surrounding inflammation, we're seeing this focal abscess at that fracture defect. So there's a communication because it didn't heal. There's a fracture communication through the fracture defect between the sinuses and then the periorbital soft tissues. So this patient treated again with antibiotics, and we're approved for that. And I think they're currently actually in the process of being planned for surgery to fix that definitively. All right, so our next patient is a 3-year-old who had known bilateral nasolacrimal duct stenosis congenitally and is now status post-balloon dacryoplasty. Now that worked on the right, but was unsuccessful on the left. So we can see the patient's presenting worsening erythema around the left eye. On the post-contrast CT exam that we did for this patient, when they presented through the ED, we can see enlargement of the left lacrimal sac, which demonstrates peripheral enhancement. And there's also the surrounding soft tissue inflammation and edema consistent with preseptal cellulitis. This patient was admitted for IV antibiotics, and they're scheduled with optho to see what further management is needed. But yeah, so nice to look for the asymmetry, this kind of a balloon appearance of the nasolacrimal duct, and then you can see it nicely on axials as well, the continuation on the coronals. And I just say, it is most common that you'll see preseptal cellulitis with these associated with these patient symptoms, but always important to get CT imaging to make sure you get the full extent of disease. Is there orbital cellulitis or any kind of evidence of intracranial extension? Okay. So this next patient is a 4-year-old who presented with daily fevers, URI symptoms, eyelid swelling, and cervical adenopathy. So this patient presented through the ED. They did an MRI, brain and orbits, as I'm showing some of those images here. So we can see abnormal enhancement and soft tissue thickening in the superficial periorbital soft tissues, suggestion of eyelid swelling as well, consistent with what they were seeing on exam. The arrows on the DWI, the arrows on the DWI image help show this marked prominence of the of the glands within the orbit superiorly, the lacrimal glands. Again, consistent with dacryocystitis, which is what they were worried about based on the patient's eyelid swelling and their symptoms and physical exam findings. So just a nice kind of prominent example of this. I think the DWI, while these glands do tend to have restricted diffusion, I think the DWI just helps accentuate the abnormal enlargement of the structures. And then just I have a representative axial T2 image for this patient, just showing the adenopathy that they had also noted on physical exam. So for this patient, dacryocystitis can be secondary. It can be infectious or inflammatory. Infectious organisms can include Staph aureus or EBV, which ended up being this patient was serology positive for EBV. If you think about inflammatory causes, that can include IgG4 related disease. So it's just some differential considerations to keep in mind depending on the clinical context. Okay, and then as we know from our medical school training and residency, EBV also tends to have prominent cervical lymph nodes, especially posteriorly. So consistent with that diagnosis. Okay, and then my last orbital case I have is a 10-month-old who presented with left eye swelling and erythema. So on the imaging, the initial MR is shown at screen left, and we can see proptosis with periorbital edema, inflammation, infection, and then we can get a sense from some of the images I've shown that there's retrobulbar inflammation and infection as well, helping to explain the proptosis. So a patient was diagnosed with orbital cellulitis, as we see on the imaging, and they were treated with antibiotics, and their symptoms improved. Unfortunately, as will be a theme for today, is that their symptoms recurred after cessation of the antibiotics, and they presented with new fevers and swelling. So a CT orbis was done at that time to further investigate what was going on. CT orbit imaging at screen right shows that there's a well-marginated perisutural tract consistent with a dermoid sinus tract within the left orbital wall. So this is a orbital dermoid sinus tract leading to recurrent orbital cellulitis. For those of you, as a reminder, dermoids can occur, whether it's a tract or a cystic lesion, they can occur along the frontoethmoidal suture or the zygomatical suture. As in other locations, if you do see a tract, it's important to always look for the tract, but if you see a tract, it's important to remember the association that the patients can have recurrent infection because of that. So always important to assess for that so you can help predict any future recurrent infections in these patients. Okay, so moving away from the orbit, we're going to move on and discuss pharyngeal infections, so painful swallowing. And to help introduce these entities, I've included, to start off with, just some representative imaging from different children who had presented with throat pain through the ED with difficulty swallowing. And for all of these patients, we got a CT neck with contrast to help look for abscess or any other emergent pathology needing attention. All right, so I'm just starting off at screen left. So in tonsillitis, just as a refresher, so in tonsillitis, this is going to be secondary to localized inflammation and infection, resulting in enlargement of the palatine tonsils. You see the striated morphology of the palatine tonsils, and in the absence of abscess, it should look relatively symmetric. You'll always see some component of airway effacement and narrowing, depending on the degree of tonsillar enlargement. Also, reactive lymph nodes are often seen in this setting, as we're seeing in this patient's example. As infection evolves, and if it's left untreated and evolves, you may get, in the next step of kind of the stage of infection, you can get either phlegmonous changes or frank abscess within the palatine tonsil itself. So that's what I'm showing in the next two steps. We have tonsillar phlegmon and tonsillar abscess, and this really is a continuum as the infection worsens. So these areas of little hypodensity within the tonsil, there's some associated peripheral enhancement, but we tend to call them phlegmon when they're small like this. In the adult literature, some studies have shown that anywhere between 3 and 3.5 centimeter, you're more likely to drain something if you try to. So certainly this is smaller than that in this teenage patient. So I think we can kind of use that data to help guide us. But and just a point before we move on. So for the phlegmon, and then when you get an abscess, again, that's confined to the palatine tonsil. The tonsillar abscess won't, even if it's larger, they usually will try to treat those just with IV antibiotics alone, with as an initial treatment step. So kind of when we're in this category, this is kind of IV antibiotic territory, IV antibiotic territory. All right, and then as the stage of tonsillar infection continues, we have peritonsillar abscess at screen right. Again, this is when the infection has continued to spread untreated, or ineffectively treated, I should say, and then will spread into the adjacent parapharyngeal space and adjacent spaces. Often for parapharyngeal abscess or peritonsillar abscesses, parapharyngeal involvement, an IAD and IV antibiotics will be required. All right, so the next patient I'm going to discuss in this section of the talk is going to be a 7-month-old who presented with fevers, fussiness, dehydration, neck stiffness, and kind of limited neck mobility. It's a grainy CT, 7-month-old, so low dose, as we would hope, but a little grainy, but we can still see the pathology importantly. So on the CT scan, post-contrast, we can see that there's this large, not subtle, large peripherally enhancing retropharyngeal collection. That's especially on the sagittal, you can see its full extent. It extends from the nasopharynx superiorly, and then extends inferiorly all the way to the level of the mediastinum. And we see that nicely on the axials. I've denoted the collection with the asterisks here. Importantly, you always want to look and see so this is an abscess, retropharyngeal abscess. Importantly, always try to see what it's doing to adjacent structures. So there's a little bit of narrowing of the IJs, but importantly, there's also deviation of the airway. While we're certainly worried the fact that the abscess is in the mediastinum, because that can lead to mediastinitis, we're also worried about airway compromise in this patient. I included this case just to have a moment to discuss the retropharyngeal space, danger space. So the danger space is going to be a space that's posterior to the retropharyngeal space, and it represents a potential conduit for infection spreading from the pharynx to the mediastinum. So in this case, presumably danger space was involved because we're seeing that extension into the mediastinum. But sometimes the inferior extent of the collection can help suggest a predisposition to be in the mediastinum. So when you have a retropharyngeal collection, certainly it's a no-brainer in this one, but if you have a retropharyngeal collection, try to look at the inferior extent of that and see if we should be worried that this could be going into the mediastinum if left untreated or ineffectively treated. So for 2 reasons, because of the involvement in the mediastinum as well as the potential airway compromise, this patient was emergently went to emergent IND for treatment. All right, this next patient presented to the ED with deep throat pain, neck pain, and torticollis, and that had been going on for a few weeks, but getting worse. So on the CT neck that we did through the ED, we can see that there's not subtle retropharyngeal abscess. I've added an arrow to it. It's peripherally enhancing, kind of has a little bit of heterogeneity internally. The other thing to note, when you look at the bone images that I've included, you can see that there's an asymmetry of the atlantodental interval, and not subtly on the coronal imaging, and especially on this 3D reconstruction, we can appreciate that there's a head tilt, helping to kind of show us what the torticollis looked like clinically. So this is a case of Grisel syndrome. Grisel is a non-traumatic atlantoaxial rotary subluxation that can accompany pharyngitis, retropharyngeal abscess, or even it can be seen after ENT surgery. But patients present with a fixed rotated head. They'll, especially in the setting of infection, they'll also have symptoms related to the infection, such as neck pain or difficulty swallowing. Several hypotheses exist in terms of why this rotary subluxation happens in the setting in these clinical scenarios, but I think they all kind of lead to the same, that some kind of inflammatory mediators are tracking along the airway and affecting the ligamentous structures. But regardless, the patients, because of the rotary subluxation, they're going to need reduction and immobilization to some degree, depending on how long this has been going on for. And then they'll also need treatment of infection if that is in fact present. All right, so this next patient is a 16-year-old who presented with fevers and neck pain. So admittedly a little challenging because they're intubated. But if we scrutinize the imaging, we can see that there's a little bit of asymmetry in the tonsils, a little bit of heterogeneity on the right, and probably more helpful, we can appreciate that there's this retropharyngeal collection that's hypoattenuating, not peripherally enhancing. So this isn't an abscess like our earlier case, but probably there's a reactive retropharyngeal effusion related to some kind of tonsillar pharyngitis process going on. I've helped you with the arrow, but we can see that there is an asymmetry of the IJ, so a filling defect within the left IJ as well, concerning for left IJ thrombus or thrombophlebitis in the setting of infection. Okay, so that was initial imaging. The patient was treated with antibiotics, but then represents, unfortunately, with worsening symptoms and respiratory distress. So a CT chest was obtained at that time, and we can see that there are these new cavitary foci within the periphery of the lungs. So this imaging is classic for the triad seen, or the imaging triad seen in Lemierre syndrome, which is pharyngitis, with some neck vein thrombosis and then cavitary pulmonary nodules. Now, the metastatic infection can involve the bone as well as the lung. It just has to be some kind of evidence of metastatic infection, but I think cavitary pulmonary nodules is what from septic emboli is what we see most commonly. In terms of etiologies or inciting factors for Lemierre's, pharyngitis is the most common thing we see. The common bug to be aware of and associated leading to Lemierre is Fusobacterium necrophorum, but there are other things that can lead to Lemierre as well. I would say in general, Lemierre is for a while was considered the forgotten disease because it was more common in the pre-antibiotic era, but with emerging antibiotic resistance, we're seeing this more commonly in clinical practice. Patients, importantly for treatment, they need to be treated with IV antibiotics as well as anticoagulation because of the thrombus or the thrombophlebitis. Okay, so next we're going to move on and discuss facial and neck swelling, and we'll kind of do this a little bit part depending on well, we will break this up a little bit, I should say. So we're going to start with parotid space and periorbital infections. All right, so this first patient is a 14-month-old who presented with right periorbital swelling and tenderness. And then initially, and then as their symptoms over a week or so, they had worsening symptoms and had a new lesion within the right submandibular space as well. Importantly, there were no systemic symptoms. They weren't having fevers, chills, or anything to that effect. So just these lesions that were painless on exam. So they presented to ENT, and then an MRI was obtained. And again, this is their first MRI. So we're seeing on the imaging, if we attention the right parotid region, we're seeing inflamed lymph nodes. In that area, there's also a little bit of signal within the adjacent parotid gland. And then I think on the coronals, it's best appreciated that you see this draining tract from the lymph nodes to the skin surface. If we take a look at the submandibular space now as well, we can see that there's abnormal lymph nodes in that location as well. Again, not too much in terms of inflammation surrounding them, but then this abnormal lymph node also has, or infected lymph node also has a draining sinus tract to the skin surface. So these are imaging features, as I've added to the slide. These are imaging features classic for non-tuberculous mycobacterial infection. So atypical TB occurs in preschool-age children who are otherwise systemically well, I should say, much like the patient I presented. In terms of locations, the periorbital region, like parotid space region, as well as the submandibular regions are common areas for lymph node involvement, again, as we saw in this case. In terms of treatment, these children will go to resection. And it's important when you're discussing these cases with your ENT surgeons, what they need to know is not only where the disease is, but also what's involved. Is there a tract where is the tract, and what adjacent structures involved. So are the muscles involved? Are the parotid or submandibular glands involved? Because they're going to try to take a cuff of all of that tissue to try to help prevent recurrence. Because if they leave any of that tissue behind, the patients unfortunately will get recurrent infection and have to go to surgery again. All right, so that was the patient's initial MRI. This patient then had follow-up imaging for new inflammation and new concerns of infection. So the second MRI I've shown here at screen left. So we're seeing new inflammation or different appearing infection inflammation involving the right parotid gland. So there's still kind of stranding in the soft tissues, and actually more so than we saw in the last exams, right? Because there wasn't a lot of that perilesional edema. But in this case, we're seeing this kind of lobulated T2 hyperintensity and then infection involving the adjacent parotid gland and lymph nodes. And then on the post-contrast, we can kind of better appreciate that there's this comma-shaped cystic structure there with all of this enhancement and infection edema surrounding it. Okay, so this was concerning for, okay, well, first of all, let's talk about the third one. So the patient was treated with antibiotics, came back for follow-up imaging to further assess the area. And we can see that there's this persistent comma-shaped T2 hyperintense lesion within the right parotid region, in periorbital region, maybe a little bit of residual enhancement from sequelae prior infection, but certainly no ongoing edema, or infection. A lot of that edema has improved. So these are classic imaging features and something we see a lot with our ENT population, clinicians, I should say, but this is a branchial cleft 1 anomaly. And again, we're going to see these most commonly in the parotid gland or the periorbital region. These lesions may present as a painless mass, or they can present with a recurrent infection, as we saw in this case. Treatment, similar to atypical microbacterial infections, treatment for branchial cleft 1 anomalies is going to be complete resection of the cyst, the fistula, and the involved tissues to help prevent recurrent sinus or fistulization. So this patient, this was I think an educational case because they had both pathologies subsequently that were path proven. So yeah, very interesting case, or educational for all of us. All right. All right, so moving on to the next space. So we talked about parotid space infections, periorbital infections. So let's talk about submandibular space infections and see if we can hone the differential a little bit. All right, so this, and you may already know what this pathology is, just by looking at it quickly. So this is a 2-year-old who presented with left neck swelling. It's increasing in size. It's not painful. There's spontaneous drainage to the skin surface. I have the diagnosis here, but this looks exactly like the last case, but on the other side. So we see abnormal lymph nodes that have a matted appearance. There's no surrounding inflammation. And then we can see that there's this nice draining tract, or very clear draining tract to the skin surface. So another case of non-tuberculous mycobacterial infection. We see this all the time, very common. So really important to be kind of familiar with this diagnosis in the pediatric population. Like I said, these patients are systemically well, and this is going to be a common location for both the parotid area as well as the submandibular region are going to be common locations for this infection. Especially as we saw in that last case, though, this can be an imaging mimic for branchial cleft anomaly, or it may be hard to differentiate them. So just keep that in mind as well. Okay, but moving on, our next patient is going to be an 18-year-old who presented following recent tooth extraction. They had refractory jaw pain that really wasn't improved by pain medications. So we got a post-contrast CT neck for this patient, and we can see a peripherally enhancing kind of heterogeneous central necrotic mass-like lesion in the right submandibular space. There's surrounding soft tissue swelling, and this is concerning for an abscess with associated cellulitis. If we attention, so I'll give a disclaimer that this was during the pandemic when access to dental care was challenging. So always, especially whenever you see an infection, and I think that that had something to do with the delayed presentation for this patient. But we can see that this has been going on for some time if we look at the bone imaging. So we can see that if you look at the medullary space, it's sclerotic, showing that, again, this infection has been longstanding. Admittedly, they did eventually get the tooth extracted. We can see the socket here, but the sclerosis within the mandible is a sign that this infection has been ongoing for a while. So not surprising that they eventually got the odontogenic abscess. The other thing to attention on the bone windows and to pay close attention to when evaluating these patients is look at the margin, the buccal margin of the mandible. You can see it's slightly irregular and there's a little bit of reaction there. So kind of related to that ongoing infection, concern for some osteomyelitis going on within the bone. So this patient will need IV antibiotics. It's important to note the bone findings because that may require that they have longer antibiotic therapy, but then also, of course, they'll need IND drainage for the abscess. Okay. Next patient is an 8-year-old with recent oral cavity surgery for ranula resection or fenestration and was presented within 24 hours with rapid neck swelling. And because of their symptoms, and the rapid neck swelling, they were actually intubated prophylactically for their airway protection. So CT was done after that, as we can see. But we can see that there's extensive inflammation in the submandibular soft tissues, sublingual spaces. We can even see thickening of the platysma muscles here, but extensive inflammation and cellulitis going on within the soft tissues. If you note on the sagittal image, of course, we see the endotracheal tube, but even within that, the tongue is pushed up and then also posteriorly by all of this inflammation within the soft tissues. So these are findings, imaging findings consistent with Ludwig angina, which is a rapidly progressive, life-threatening cellulitis. You don't necessarily have to have an abscess, and I think it's actually more common to see this with cellulitis. Often it's odontogenic, wasn't necessarily in this case, but often Ludwig angina will be odontogenic in etiology. And patients will manifest or present with this kind of firm neck edema. They'll have associated dyspnea, drooling, and concerning symptoms. Early intubation, as was done for this patient, is important to help maintain the airway while the team can help work on managing treatment for whatever infection may be going on. Okay, so this next patient is an 18-year-old who has lupus, and they presented with acute onset neck pain and swelling. Importantly, they were endorsing nasal congestions, upper respiratory symptoms, but also this marked submandibular swelling. And if we take a look at the imaging, we can see some of what they were feeling on exam. So there is this marked enlargement and heterogeneity of the bilateral submandibular glands. Sublingual glands we can partially see here are also enlarged. And then we can see that the parotid glands are also markedly enlarged and heterogeneous. In addition to that, we see that there is this marked inflammation within the soft tissues. So thickening in the platysma muscles, as well as this stranding within the soft tissues concerning for cellulitis. So all this to go, and then also there's an arrow here. We can see kind of helping to kind of piece together the imaging appearance. So another thing to help support that there's something other than just sialadenitis going on and some infection, we see a reactive effusion in the retropharyngeal space. So together, this finding, as I put on the slide, this was attributed to sialadenitis, we can see with lupus, but also they had this superimposed cellulitis, and that was also attributed to some of their presenting symptoms. They had been having kind of more nasal and throat pain and upper respiratory tract like infection symptoms as well. So ultimately, thankfully, this patient didn't need, despite all the stranding and inflammation, infection, cellulitis, they didn't need intubation, and they were treated with antibiotics and did well upon discharge home. Okay, our next patient is a 15-year-old who presented with left neck pain. They had also endorsed that they had these skin bumps within their neck soft tissues that had been becoming more prominent. And then more recently, right before they presented, they had this limited range of motion of their neck. Of course, this patient has a few cats at home, including a new stray cat that they just recently adopted and brought home. So this patient on the image, we can see these very vague, kind of hard to see, not avidly enhancing, but heterogeneous lymph nodes within the left submandibular space and adjacent soft tissues. And again, especially with the history, all other serologies came back negative, but Bartonella was positive. So this was secondary to cat scratch or representative of cat scratch disease. So cat scratch is going to be secondary to Bartonella henselae, as we know from medical school. Pathophysiology-wise, this results from inoculation of the skin by a cat scratch, and the involved lymph nodes will be, or the reactive adenopathy happens kind of downstream from the draining lesion on the skin. Usually you'll see the adenopathy occurs about 1 to 2 weeks after the inciting event. In terms of locations, axilla is most common, but as we see here in this case, head and neck locations can be seen as well. Oftentimes patients self-resolve without treatment. This patient actually got azithromycin for progressive disease, but also some patients may require IND if they end up going on to abscess formation, depending on when they present. Okay, so this next patient is a 14-year-old who presented with left cheek and mandible swelling for a few weeks. On physical exam, they actually had firm, kind of enlarged lymph nodes. So on physical exam, the clinicians were worried about neoplasm. So they got a CT neck and an ultrasound to kind of further evaluate what was going on. So starting with the ultrasound, we can see that there are these enlarged lymph nodes and then if we look at the vascular hyla, they're very hypervascular. So hypervascular hyla and large lymph nodes, when we correlate that with the CT neck, we can see that there are unilateral, homogeneously solid enhancing lymph nodes. And although some of them do have these areas of necrosis, which you see in this image as well as on the coronal image, there is some inflammation as well. So there's a question of whether there's some kind of superimposed infection, the platysma is thickened, and there is some stranding with the adjacent soft tissues. Because of the concern for lymphoma and possibly lymphoma with superimposed infection, the patient went on to biopsy, surgical biopsy for further characterization and diagnosis. And this was path-proven Kikuchi disease or Kikuchi Fujimoto disease, which is a benign idiopathic necrotizing cervical adenitis that's most common in young Asian adults. As I've mentioned or alluded to, this is a clinical and imaging mimic for lymphoma and requires biopsy for confirmation. Because of the stranding that's often associated or classically associated with these abnormal lymph nodes, it's also a mimic for infection. So it can be a little bit of a imaging conundrum, but very uncommon. But I thought it was a nice kind of imaging mimic to throw in here just to help spread the differential. Okay. So last but not least, I'm going to spend some time kind of rounding out the discussion and review a few other neck fascia infections to keep in mind. All right, so this first patient is a 3-year-old with left-sided lymphadenopathy, fever, and drooling. We first did an ultrasound, which shows enlarged lymph nodes. This image here shows that there's hypervascular hyla within the lymph nodes. But also this ultrasound image at screen left is showing that there's no vascular hyla within this lymph node, and it's actually centrally necrotic with hypoechogenicity in there. A CT neck was done next, and we can see that there are these centrally necrotic lymph nodes with surrounding inflammation and cellulitis. And then I think the sagittal is really nice to help you follow the morphology of what you would expect to be a lymph node, and then see central hypoattenuation within it. I think differentiating the ultrasound in this particular case, I think, is particularly helpful for differentiating abscess and separative lymphadenitis, because you can still see the lymph node contours really nicely on the ultrasound. So the treatment for this was IV antibiotics and IND, plus or minus depending on the size of the lesions. I think this patient went on to IND. Okay, our next patient is a 14-year-old who presents with a couple months of worsening, unrelenting cervical lymphadenopathy. So on CT, we can see that there are multiple slightly heterogeneous lymph nodes within at multiple levels within the neck soft tissues. And we can see that they're surrounding inflammation and kind of attenuation within the adjacent soft tissues. So this is a companion case for the last case I showed. This is non-suppurative lymphadenitis, and just to help show what that would look like, this is a case of actinomyces, non-suppurative lymphadenitis. Okay, so our next patient is a 6-year-old who has who's presenting with non-painful right neck mass with a draining fistula. So we can see, as denoted by the arrow, there are these centrally low dense, centrally necrotic kind of matted lymph nodes within the right neck. Sometimes you'll hear these referred to as cold abscesses because of that absence of surrounding inflammation, much like what we saw in the atypical mycobacterial infection. Calcification is present in this case, as shown here. And this is a classic example of tuberculous cervical lymphadenitis or scrofula. These infections are common in patients from endemic areas. It's also important to remember scrofula or TB lymphadenitis in immunocompromised patients. So this patient, again, cultures were positive for TB as well. Patients, as was similar in this patient, clinical patients present with they can be bilateral, painless cervical lymphadenopathy. And important to keep in mind too for TB that outside of the chest, the cervical lymph nodes are going to be the most common extrapulmonary place of involvement. Always important to remember scrofula and TB in terms of management. These patients require it's important for isolation purposes. It's also important they need multi-drug therapy to help clear their infection. And sometimes, as was actually unfortunately the case for the patient I've shown here, if they're refractory to treatment, they'll have to go to surgery to get these resected, which was the case for this patient. All right, our next patient is a 12-year-old with neck pain, fevers, and neck swelling. And then there was concern for submandibular cellulitis on physical exam. So they obtained a CT neck with contrast to further characterize the findings. And we can see that there's this vaguely defined peripherally but centrally hypodense collection within the anterior neck soft tissues. As we go more superior, it looks more midline. As we go more inferiorly, it kind of looks like it's being owned by the strap muscles here. And then if we look on the sagittal, a little bit hard to appreciate the collection, but it's this region here. And then also we can appreciate that it's kind of has this tail that's going up to the hyoid bone. So it has a connection up to the hyoid. So this is a thyroglossal duct cyst, an infected thyroglossal duct cyst. So remembering that that's a cystic remnant of the embryologic thyroglossal duct, and it can occur anywhere along where that tract route, that duct route would have been. So anywhere from the foramen cecum at the tongue base down to the thyroid bed. This patient went on to get IND, but importantly, the definitive treatment for these patients will be a cyst trunk resection that includes resection of the cyst, the tract, and then the midline hyoid bone. And similar to what we were discussing earlier with the atypical TB infections and the branchial cleft anomalies, important to resect all of it to help prevent recurrence. Okay, so our next patient is an 9-year-old who has an enlarging left neck mass on physical exam, and they're reporting tactile fevers at home as well. So on imaging on the CT neck with contrast, we can see this peripherally enhancing lesion that's underlying the sternocleidomastoid. It's posterior to the submandibular gland. It's going to be lateral to the carotid sheath, so helping to localize this. There's marked surrounding inflammation and edema, as we can see with this outpouching of the soft tissues. This patient went on to get IND, as I'm showing with this ultrasound image. And then they came back to get an MRI to further look for an underlying lesion. Given the location, this is a common location for a branchial cleft 2 anomaly, which is what this ended up being. So we can see this persistent cyst, branchial cleft cyst within the soft tissues, as I'm pointing out with the arrow. And branchial cleft cyst was, again, confirmed at surgical resection. So just like a branchial cleft 1 cyst, or anomaly, this needs to be completely surgically resected. The cyst, the tract, again, to attract if present to help prevent recurrence. Okay. And then finally, this is last patient for this section. This is a 4-year-old who presented with fevers, left neck swelling, left neck pain that had been going on for about a week. So we can see on imaging that there's this heterogeneous collection. And if you scroll too closely, you might think it was in the palatine tonsil, but this is a little bit too posterior. And in the wrong location for that. So this is actually at the level of the supraglottic larynx, and it's going to be posterior left lateral supraglottic larynx is where it's starting. If we track it down, it terminates at the level of the left thyroid lobe. So in a different pattern than what we were seeing with the palatine peritonsillar abscesses earlier. So there's inflammation surrounding this as well. And if you look at the coronal, we can nicely see the full extent of this lesion. So this is another branchial cleft anomaly. This is a 3 or 4. In practice, it's very hard to tell the difference between a 3rd or 4th branchial cleft anomaly. We discuss it with our ENT surgeons all the time, and I think it's hard to know that de novo from imaging alone. Most of these tend to happen on the left side of the neck, and they can present with recurrent thyroiditis or a perithyroid abscess like we're seeing in this case. But again, for this, the pearl to pick up from this case is if you see a collection that runs from the supraglottic larynx to the thyroid, think about branchial cleft anomaly, because this patient, as we saw earlier in several cases, is at a setup for recurrent infections. Okay, and then just 2 cases just to think about. So I'm going to present 2 cases for neck abscesses in infants, which I find particularly challenging in my practice. But I wanted to bring up these pearls for thought. So the first case, so this is to drain or not to drain. So on the initial CT, this is for an infant who presented with fevers and worsening left neck mass. We can see the reason for the left neck mass. There's this large abscess within the left neck soft tissues. There's edema and inflammation around it, associated edema and inflammation. So they went to IND, and then they represented a couple days later because they were still having persistent fevers after the IND, and they wanted to evaluate the abscess. So to drain or not to drain. So this one is a relatively straightforward one. So it's bigger, unequivocally bigger. And I think that's best appreciated on the coronals, and then maybe a little bit more here on this axial image. So this patient needs to go back to IND. So this is a straightforward case. And these are the ones that I like reading. The ones that are challenging are this next case. So this is another infant who presented with fevers and worsening, this time right neck mass. So fevers and right neck mass. And this is the initial CT that they had. We can see this heterogeneous collection within the right neck soft tissues. Notably, this is a low dose technique, and I think an 8-month-old. So it's grainy, it always makes it more challenging. But that said, there's a heterogeneous collection. I think on the coronal, we can appreciate that it looks like a lot of it is that there is some formed abscess within there that could be drainable. So this patient went on to IND. They did drain pus out of the lesion. But unfortunately, a couple of days later, the patient's still having persistent fevers that aren't quite responding like they would have hoped. And so they get a repeat CT neck, which we see at screen right. And they're wondering if they need to go back to IND. So when I get these cases, I always try to find the largest pocket. And so I think I'm showing some of them here and here on the coronal image. I think you get the best look at it. Ultimately, what I told the ENT was that I didn't think that there was anything that was more than 2 centimeters that would be drainable. So they didn't go to surgery on the day of this imaging. They had persistent fevers and went to surgery the following day, and they weren't able to drain anything. So I bring this case up. So again, nothing was drained on the repeat IND for this patient with this imaging appearance. So I bring this case up just to talk about what's drainable, what's not drainable in infants. So the criteria is going to be a little bit different than our adult patients. Like I mentioned earlier, some studies have shown 3 centimeter, 3.5 centimeter in adult patients. You'll get something, you'll be able to drain something and get benefit from the IND. In infants, I think it's a discussion with your ENT colleagues. 2 centimeters is a good ballpark, but then it's going to depend on the patient and other factors and whether they've been on antibiotics. So I think it's a discussion, a multidisciplinary team discussion to have always, especially when you get imaging that looks like that case I'm showing you now. Okay. So just in summary, I think a location-based differential diagnosis is helpful when assessing head and neck infections in children. Follow-up imaging or additional imaging should be considered to help exclude an underlying congenital lesion, especially when you have recurrent infections, as we saw in some of the cases I presented. And then finally, remember that children are not small adults. A multidisciplinary team approach is going to be helpful to help guide management and treatment decisions, especially for cases like I just showed, where it's a little bit more complex and less straightforward. And here are my references, and thanks to everyone for your attention.
Thank you so much, Sarah. That was awesome. Some great cases. If anybody has any questions or comments, feel free to put them into the chat. I always find it, going back to the tonsil, peritonsillar abscesses, I always find it a little bit difficult sometimes to differentiate or come down hard. Is it definitely a tonsillar abscess, or so I mean, do you come down hard if it's, you really think it's a tonsillar abscess or peritonsillar abscess, or hedge a little bit sometimes, or?
I mean, I think sometimes too, we get one look at it. But I think I find the coronal is helpful too to help differentiate it. But if you can't tell, then say tonsillar, peritonsillar. And if it's large enough, they may be able to drain something. It's not that you can't drain a tonsillar abscess, they tend not to. So I think if it's large enough, they probably still can just drain it. It's just that those tend to respond better to antibiotics. So I think size is helpful, largest dimension.
Okay. Any questions from the audience? Everybody's there. Yeah, everybody. Yeah, these are some great cases. I think everything was pretty clear. I think everybody is an expert now.
Hopefully. Well, probably more than I was at level of training, but yeah, I think anyway, thanks everyone for attending today.
Yeah, thank you so much. And then yeah, everybody have a great holidays, and hopefully see you guys next year for another session of peanuts. Thanks again, Sarah.
Yeah, thanks everyone.
Yeah,
Happy holidays.
take care.